Thank you. Can everybody hear me? I hope so. So firstly, thank you very much, Brian, for that very kind introduction. You and I have known each other for a very long
A long
time,
time.
and but the important thing is we stay young by keeping up with focal therapy. Focal therapy itself is a relatively new technique in the armamentarium of treatment of prostate cancers, and we're, like you said, we're constantly trying to strive further forward and leading the way in developing new technologies and new techniques to try and facilitate a better treatment, minimally invasive treatment for a lot of men out there. Now, I know that I do not know the whole audience, but I know some of you will know me, some of you will not know me, and some of you may want to know me in the future, or some of you may not want to know me in the future. But as Brian says, that I'm a focal therapist, but a urological surgeon at heart, and have been involved in the care of men and men's health andrologically as well. So that deals with erectile dysfunction, particularly from prostate cancer treatments, as well as fertility issues and male hormonal issues. So it's a subject very close to my heart, and a lot of it does correlate with prostate cancer and the treatment of prostate cancer. So I feel that I am uniquely placed to be able to discuss both of these issues. So if we start our talk, prostate cancer, as we all know, is a huge subject. I'm just going to concentrate on two or three little areas here, and I've already seen a vast number of questions being sent in, which is wonderful, and we'll try and answer as many of those as we can, perhaps in the talk or after the talk, if required. So here we go. What I'm going to be talking about is what I think is very, very topical at the moment. Screening, a bit about diagnostics, and obviously some of the focal treatments and their comparisons to the standard traditional treatments, if you like, that exist today. Barely a week goes by without something on prostate cancer, as most of you will know. I'm just trying to change the slide. There we go. We all know it's a major, major problem. And it's the most common male cancer now in many countries, certainly in the West. It's a significant cause of mortality as well. This adage of you're more likely to live with prostate cancer than die from it is certainly true for certain low grades of cancer, but a lot of men are still dying, sadly, from the cancer. It increases as we all get older, and the risk increases significantly after the age of 50. Men of Afro-Caribbean or African American origin are known to have a much higher incidence, not only of the cancer itself, but also of higher mortality compared to other ethnic groups. Family history is also vitally important. And it's really important if you have sons and so on, or if you're younger and you want to get your father tested or your uncle tested and so on, that should take place. Lifestyle factors. I'm asked about this every week by a patient or other. A lot has been studied, but the hard and fast evidence is limited. Nevertheless, there are certain diets, Mediterranean type diet, and so on, limiting obesity, limiting animal fats, and so on, is all vital in terms of improving your own lifestyle, whether you've got cancer or not. Smoking has been studied, and it's one of the few cancers where there does not appear to be any great association. We know it's increasing in many countries. In the UK, sadly, 1 in 8 of us is going to develop prostate cancer, and it's even higher in African American or Afro-Caribbean men, 1 in 4. Overall mortality in the UK is about 12,000. This has interestingly decreased in the last decade, but the prevalence and the incidence of the condition has increased. Now, why has mortality decreased? We would like to think it's because of treatments and so on, but it's not always the case that treatments lead to a decrease in mortality, but certainly earlier diagnosis does help. We know that a lot of men will survive for 10 years, no matter what treatment they have. I'll briefly allude to the PROTECT trial later. Significant variations, sadly, still occur in the UK. And we in the focal therapy clinic see patients from all over the country, from John O'Groats down to Land's End. We've treated men from literally all over the country and around the world when they come to contact us. And sadly, there are still significant variations in mortality and prevalence within the UK. And it is estimated that there are, at this stage, at least 500,000 men who are living with for or have been treated for prostate cancer. And this is only predicted to increase considerably in the future. To the right is a busy slide from the National Prostate Cancer Audit looking at some conditions and so on and treatments, but I will come back to that later. As I said, barely a week goes by without something in the news headlines and so on. And screening has been at the forefront of the journalists and so on, and the media attention, as well as the government and the Secretary of State for Health. So we know that a lot of people, particularly celebrities and politicians, are intervening in the debate, and rightly so. But this has to be considered in light of the evidence. So Lord Cameron recently came out that he had developed prostate cancer. And out of all the choices that he was given, he chose to have focal therapy. And he's made, I can share that because he's not, decided to hide that fact. He had the standard precision guided diagnosis and treatment with a PSA, multiparametric MRI, and targeted biopsies. And following that, he chose focal therapy for his treatment and then released the information to the media a few months after his treatment. So what exactly is the evidence? And it is contradictory. Intuitively, we all might think that it's such a common condition. Why on earth aren't we, screening for it? But it's a bit more complicated than that. There was a very large European trial, European randomized study of screening for prostate cancer. 8 countries were involved over a 20-year plus period. Results were published a couple of years ago, and they showed that there was a 13% reduction in prostate cancer specific mortality in the screened group. So you might think, great, that's excellent. But a lot of men had to be screened in order to prevent one death. And there are obviously cost-benefit analyses that are carried out in each country to see whether that would be worthwhile or not. Their conclusion was that the PSA screening does save lives, but the benefit is modest. If we counteract that to the US study, 400,000 men were invited to a single PSA test, and they showed no significant mortality reduction after 10 years. And these are the 2 biggest contemporary screening studies that exist. And as you can see, that the outlying evidence from both of them is contradictory. And so for simply to say that, we must have a screening program is a very difficult call given these studies. There are now new US screening initiatives, Patrol and Progress, and they're trying to involve other factors and so on. There is that last comment that I've made on that slide. There is evidence from the American Cancer Society that since screening stopped, that there is an increased presentation of advanced disease.